This is a really important topic, I think, and a very practical one for emergency medicine physicians. So I'm really glad that you guys asked me to talk about this. And really, in the context of the trauma patients, we know that trauma patients bleed a lot. It's one of the biggest things that we have to deal with every day. And if we use the amount of blood just as a surrogate marker of the sort of amount of blood that we use for these patients and the amount that they bleed, trauma patients use a disproportionately large amount of blood in any medical center, no matter where you work. And not only do they use a lot of blood, the amount of blood per patient that comes in is increasing as our transfusion thresholds change and the way we manage resuscitation changes. So in these patients who are bleeding actively onto the floor, it's very important that we know what we can do to try to combat blood loss, because it really is the biggest, most acute thing that we have to deal with in these patients. And for that patient, really, when we look at all the priorities that we have to deal with, the number one thing that we're most concerned about in these patients is stopping bleeding. And next to surgical control, probably the next most important thing that we can do is make sure that the systemic coagulation system is in order, and that way we can help with that surgical control of bleeding. Now, there's been four big things in the last 12 months or so, at least since the last meeting, that have come up either in terms of papers or in sort of practices. And these are the four things that I'm going to go over today: Factor VII, plasma, platelets, and then the CRASH-2 data. We're going to start off with Factor VII. And really, you know, Factor VII was hoped to be that magic bullet for all of us that would help us with this systemic coagulation problem. And as you all know, it was first described for human use in 1983 for two hemophilia A patients that had inhibitors to Factor VIII. One was undergoing dental surgery and the other had joint bleeding. Now, since that time, we do have a recombinant murine-based product, and regardless of which way it works, so whether it's based on tissue factor causing a thrombin burst or on the surface of the activated platelet, this increase in thrombin should then lay down fibrin, and at least theoretically, this should all happen where you want it to happen. So where there's vascular damage and the endothelium has been broken, there should be tissue factor exposed, and there should be activated platelets milling around in that area. And on the surface of those, you get a thrombin burst, and locally, where the vessels are damaged, at least theoretically, you should have nice fibrin clot being laid down, and not where you don't want it to be laid down. So we were all hoping that this would be that miraculous drug in a single shot that you could give to this actively bleeding trauma patient that would stop all the bleeding where it was actually occurring and act as that single clamp that would shut everything down. Now, this was the first description of its use in trauma. Back in 1999, it was a 19-year-old Israeli soldier, gunshot wound, IVC injury, then underwent ligation. And as the story goes, he had all this ongoing non-surgical bleeding, and it wasn't until he got a couple doses of Factor VII that it miraculously stopped. And now since then, there's been multiple case reports, case series, and even a single prospective trial. And this is the results of that first prospective trial. So it was done in South Africa and Canada. And basically for blunt trauma patients, there was a very modest 2.6 unit decrease in the amount of red cells used. And for penetrating trauma, a 1 unit decrease. But there was really no survival difference at all. And at the end of this trial, they concluded that, well, this is a very safe drug, no increase in complications. It's very easy to give, and it reduces transfusion a little bit. And it kind of reduces massive transfusion as well. The problem is, though, that this comes at a very big cost. The average dosing scheme is somewhere in the $30,000 range for the last trial that just wrapped up. And this is that trial, the control trial. It was published in the fall of last year. And this was a multi-center, multi-year study that involved 150 centers in 26 different countries. It was randomized, double-blind, very carefully done study. It involved both blunt and penetrating trauma patients that got somewhere between 4 but not quite 8 units of blood and had evidence of ongoing bleeding. And these patients were then randomized to getting 200, 100, and 100 mics of Factor VII versus placebo. The primary endpoint in the blunt arm is what they were after, and that was mortality, all cause at 30 days. But unfortunately, as you probably know, this study was terminated in July of 2008 for a primary endpoint futility when 573 of the planned 1502 patients were enrolled. And what they found, which was published last fall, was that, again, there was no difference in mortality, whether you got that $30,000 dosing scheme or not. And when you take a look at the red cell use and the FFP use, there was a statistically significant drop over the first 48 hours for red cells from 9.1 units to 7.8, and for FFP from 8 to 5.3, and there's no difference in platelets or cryo. And there was no difference in complications. So they concluded again that it was a safe drug, that it reduces transfusion, and that there is no impact on mortality and no positive benefit in terms of multi-system organ failure. But I guess the question that we all have is, although it was statistically significant, is the drop from 9.1 units to 7.8 units really clinically significant? I know practically this probably mirrors what's happening at your centers. During the middle of the trial, from August of 2006 till September 2007, 42 trauma patients had doses of factor VII, 383 vials, totaling nearly $500,000. In the last 12 months, so in all of 2010, we had 3 patients using it. So its use has dropped dramatically. Now, there are no further trials planned for the trauma patient population, and I know that off-label use continues. It does continue at our center as well, but the optimal patient and the true indications for giving this are really unknown. Okay, so that's factor VII. Now, what about plasma? We know that when we talk about coagulopathy in the trauma patient, there are multiple reasons why this happens. There's component loss, there's dilution, there's consumption, and added to that, there's the problems with acidemia and hypothermia. And when we try to decide how much plasma, when you're sitting down in the emergency department, to give to these patients, it's very difficult. Quantifying the amount of blood that these patients are losing is notoriously inaccurate. Lab values are really slow, and because they're so slow, the accuracy is really questionable. And for patients like this is the elevator that leads from the emergency department to our new operating rooms. For patients like this that are bleeding actively onto the floor, unfortunately, these lab value guided treatment regimens simply do not work. They're just too inaccurate to be of any use. So historically, we've used ratios for these patients that are actively bleeding quickly. And these ratios historically have been in the range of an RBC to FFP ratio of 4:1 or 6:1, so a unit of plasma for every 4 or 6 units of red cells. But we're now in this era of hemostatic resuscitation, or damage control resuscitation, and really that consists of 4 things: permissive hypotension, prioritizing surgical control, minimizing the use of crystalloid, and really being emphasized now is the early empiric use of component therapy. And there are many studies now to back this up. And we'll kind of go over a little bit of the literature. There's 19 military and civilian studies, and virtually all of them emphasize aggressive empiric early plasma use. And here's a typical example of a study. This is the largest single-center study that's been published. They've all been retrospective. This one spanned 6 years. And it took, like all these other studies, patients that got a massive transfusion. And that's defined in almost all studies as getting more than 10 units in the first 12 or 24 hours. And all of them have looked at the impact of varying ratios of plasma to red cells. Now, in this study, of the 25,000 or so trauma patients that came in during the study period, about 17% or so got blood. And of those, about 9% met the definition of a massive transfusion, so greater than or equal to 10 units in the first 24. You can see that as time went along, from 2000 to 2005, there was a steady increase in the amount of plasma that was given, which mirrored what was happening in the literature. And most importantly, when you stratify the patient's outcomes based on the amount of plasma that they got, you can see on the screen left, that's low amounts of plasma compared to RBC, and on the screen right, stepwise increase in the amount of plasma to RBCs. And you can see that the mortality went from 90% when you got not much plasma all the way down to 26% as you increase the amount of plasma. And when you run this through a regression to control for all the differences between the groups, one of the strongest independent predictors of survival was a higher ratio of FFP to RBCs. So when you look at the literature, although the studies are all retrospective, and certainly the numbers are relatively small, the results are very consistent. It applies to both the civilian patient population as well as the military patient population, and all of them say that plasma really is probably an important thing for us to consider. Now, a couple things for people that work at moderate-sized programs where you may not yet have access to thawed plasma. there's a couple things that can be done to optimize the delivery of plasma into your emergency department. Now, as you know, there's really two products available on the market here in the U.S. There's FFP, which is plasma that's been frozen within the early time limit set by the system. And then there's FP24, which means that the plasma has been frozen within 24 hours of collection. Now, all of this is stored at least minus 18 degrees Celsius and can last for up to 1 year. We store ours, this is our freezer at LA County, at minus 30 degrees Celsius. And in order to get it from that chunk of ice down into a usable form, it needs to be thawed. Now, this whole thawing process can be done through a microwave. It's an FDA-approved microwavable device, or as at County, and in most places, an agitated water bath. It takes about 16 minutes or so to thaw 8 units of plasma. Now, this is dispensed as a type-specific product, so that means that ABO cross-matching or ABO grouping needs to be done. It takes about 5 minutes or so, and the whole thaw process takes 20 to 30 minutes. So when you add that together with the transport time, the total time taken to get plasma into the emergency department is usually 45 to 60 minutes. And during that time, for a rapidly bleeding trauma patient, you can lose and replace that red cell volume of that body several times over. So one of the things that can really hasten or improve the time to delivery of plasma into the emergency department is the availability of liquid or thawed plasma. Because once this plasma is thawed, you can actually keep it. It's relabeled once 24 hours has passed as thawed plasma, but even then it can be kept in the fridge at 1 to 6 degrees Celsius for another 5 days or so. And all of the coagulation factors within this plasma degrade fairly slowly. Even factors 5 and 8, which are the most heat-labile factors. And because any system will dispense the first unit that came in, i.e. the oldest unit, out first, there's very rapid turnover, and it's very rare for this thawed plasma to get wasted. So at LA County, for example, we house 10 units of A, 10 units of O, and 4 of B in a pre-thawed state, liquid and ready to be dispensed, which really means that we can get plasma into the emergency department very quick. Right now, we actually don't have any of the universal donor AB plasma in a liquid form because it's fairly rare, but we will start that, and we're going to start housing it in the emergency department this fall. It's available immediately for use with really minimal wastage, and the turnover is usually less than 24 hours for each of these units of plasma, although it can extend up to 5 days. So the summary with plasma is that we really probably, based on the best available evidence today, should be targeting a ratio of 1 to 1. Now, this is all for patients requiring a massive transfusion, and in this patient load, it's been shown to improve outcomes. Now, the tendency, of course, is that, with all this data out there supporting a 1 to 1, the moment that first red cell unit or the second red cell unit goes in, our tendency is to start to want to match that red cell unit, the first or even the second, with plasma in a 1 to 1 ratio. But I think it's important to remember that there is no data to support the early use of this in patients that are not getting a massive transfusion. And in fact, if you actually look at the literature, we took a look at those patients that got blood but didn't achieve getting a massive transfusion. And we asked the question, what is the impact of getting plasma in those patients that got some blood but not a massive transfusion? You can see that over that same study period of about 5 years or so, there was about 1,700 patients or so that got some blood, but not quite enough to meet the definition of a massive transfusion. When you look at those patients, a good third of them or so were exposed to plasma of varying amounts. And regardless of the ratio of plasma achieved, so whether you got a 1 to 1, 1 to 2, 1 to 8, there was no difference in survival, no matter what the ratio was that you achieved. And in fact, for those patients that got exposed to plasma that didn't get a massive transfusion, not only was there no survival benefit, but there was double the complications. And if you actually look at them, depending on the amount of plasma you got, as you increase the amount of plasma these non-massively transfused patients got exposed to, there was a stepwise increase in the overall complications, there was a stepwise increase in the ARDS rate, and a stepwise increase in the multisystem organ failure rate. So I think although for patients getting a massive transfusion, plasma can be beneficial, if the patient does not arrive with a coagulopathy, we will wait until the first 6 to 10 units of red cells have gone in before we start transfusing plasma. Okay, now what about platelets? Well, there are relatively fewer papers looking at the ratio of platelets. In fact, there's 3 right now that are out in the literature. This, again, is the largest single-center study looking at the use of platelets over a 9-year period. And again, the plan for this paper was to look at the ratio of platelets to red cells to see what kind of impact increasing the amount of platelets had on outcomes. Now, at our center, as in most centers, apheresis units are used exclusively. And because for every apheresis unit, you've got an equivalent platelet load to about 6 to 10 units of random donor platelets, 1 to 10 would be the equivalent dose that would equal a 1-to-1 ratio, because there's effectively 6 to 10 times the number of platelets in an apheresis unit. Now, in this study, because plasma is so important, and there's a lot of literature to support it, the amount of plasma that was given was also corrected for. And you can see that whether you look at mortality in the first 12 hours, where there's a very significant increase as you go and increase the amount of platelets, the survival increases. The same thing holds true at 24 hours. As you decrease the amount of platelets that you give, you have an increase in mortality, and the in-hospital mortality is the same. So whereas the transfusion of platelets is probably not as important as the transfusion of plasma, the more platelets you give as well, as you target a ratio of 1 to 10 for apheresis platelets, the better these patients do. So if we're going to summarize platelets and plasma, for both plasma and for platelets, as you increase the amount of plasma and the platelets that are transfused, there's an improvement in survival. This applies only to patients that have gotten a massive transfusion. And this is all based on retrospective data. Now, as you probably know, if any of you guys work close to these centers, there's a massive multi-center trial being started this summer. In fact, there are 4 centers already enrolling patients to get pilot data to do the actual power calculation and the final study design plans. But starting this summer, these centers will begin enrolling patients into a large multi-center prospective trial looking at this very issue. Now, it's an NIH and DoD-funded phase 3 randomized controlled trial. It's going to be done with community consultation and waiver of consent. And in this study, we're going to compare a 1-to-1-to-1 ratio up against either a 1-to-1-to-2 or a 1-to-1-to-3, depending on what's found with these first 4 centers that are collecting pilot data today. The primary outcome, of course, is going to be mortality, and the first meeting for the big trials group is scheduled in July, and hopefully by the end of this year, active patient enrollment will begin, and hopefully a year or a year and a half from now, some true prospective data to back this up will be available. So summarizing this all into a transfusion protocol, this is our transfusion protocol at LA County, and we start off with O negative or O positive uncross-matched blood, and as soon as possible, we'll move to type-specific or fully cross-matched blood. And when available, if we have labs to guide our treatment, we will go ahead and, based on abnormal coagulation data, transfuse products appropriately. For patients that have diffuse non-surgical bleeding, although the use of factor VII has tailed off considerably, it is still available on our formulary for off-label use, and in rare instances it will be used. For all other patients, though, that are bleeding way too fast for us to get any true coagulation data, we start our massive transfusion protocol. Wait until the first 6 units of red cells have gone in, and after that, with every unit of red cell that gets delivered to either the emergency department or into the operating room, a unit of plasma comes along with it, and for every 10 units of red cells, 1 unit of apheresis platelets also accompanies the blood in a cooler. Okay, now finally, if we could just talk about tranexamic acid very quickly. This is the CRASH-2 trial that I'm sure everyone's seen. And as you know, tranexamic acid is a synthetic fibrinolysis inhibitor. It blocks the conversion of plasminogen. And there's been extensive experience with this in elective surgery, but really up until now, no randomized controlled trials in trauma patients. Now, the CRASH-2 study involved 274 centers across 40 different countries and more than 20,000 patients. And the dosing schedule was 1 gram up front in the first 10 minutes, as soon as a patient arrived and was enrolled in the study, and another gram over the next 8 hours versus a placebo control. And this is what they found. There was a very statistically significant but clinically questionable decrease in mortality from 16% to 14.5%. And if you look at the mortality just due to bleeding, again, it was statistically significant, but clinically questionable, from 5.7% down to 4.9%. And when you look at the all-cause mortality, total mortality, the subgroup analysis favored getting that tranexamic acid at 3 or earlier hours and patients that were hypotensive. And most importantly, I think most of us feel there was really no increase in thromboembolic complications, whether you got a placebo or the tranexamic acid. But there's been a lot of criticisms about this study. A lot has been written about it. And these are the things that usually come up. So first of all, the entry criteria. In order to get enrolled in this study, you have to have a pressure less than 90, or a heart rate greater than 110, or in the clinician's judgment, you had to be at risk of significant hemorrhage, and the physician had to be uncertain whether or not to treat the patient with tranexamic acid, whatever that means. Now, only half of the patients, and this is a study that was testing a drug designed to stop bleeding, and yet only half of the patients enrolled in this study required any blood at all, and getting tranexamic acid did not decrease the amount of blood that the patients received at all. So in the treatment arm, there's no difference. In both arms, all told, the total amount of blood received was 6 units total. The enrolling sites were very diverse across many, many centers, 274 different centers, and the care given at these sites was not standardized. And if you actually look at the absolute reduction in mortality, it was only 1.5%. But on the flip side, you know, the trial compliance, at least as reported, was very high, and it is a very inexpensive drug. Even at LA County, that 1 gram costs only $68. And as far as could be told from this study, it is a risk-neutral drug. And if anything, because of all the criticism that's levied at this study, the magnitude of the effect probably is diluted. And if they were to hone in on the patient population that really should get it, perhaps the magnitude of the effect would be even larger. Now, I'm sure you guys have all seen or at least heard about this study that came out a week or two ago in Lancet. And this was their post-hoc analysis of the time required in deaths that were due specifically to bleeding. Now, if you remember in the initial study that was published, there's really no all-cause mortality improvement out past 3 hours. So they took a look and reanalyzed the 1,063 deaths that were due specifically to bleeding, and they asked, did the time at which the tranexamic acid, time from injury to giving the tranexamic acid, make a difference? And this is what they found. So if you got the tranexamic acid within an hour or within 1 to 3 hours of injury, there was a beneficial effect. However, if you got it out past 3 hours, there was in fact a negative effect. And this is in the cohort that we're most interested in, those that died due to bleeding. So if we could summarize the tranexamic acid, really the mechanism still is unknown. At least we know how it should work, but when you look at its role in the clinical arena, it's very difficult to tease out from the study that was done how it actually worked to decrease the mortality that it did. There are many questions unanswered, and one of the primary ones, of course, is who is the ideal patient that should get this tranexamic acid? But if you are going to give it, and it has been shown to be risk neutral thus far, it's probably best to do so early and before that 3-hour window is up. So, what are you going to do for Monday morning? This is what Sujal wanted us to cover. I think that it's probably important to consider plasma and platelet use early, but to wait until that first 6 to 10 units has gone in, unless the patient presents in a coagulopathic state. For plasma, we should probably be targeting a 1-to-1 ratio. And for apheresis platelets, we should probably be targeting a 1-to-10 ratio. The role of factor VII really is unclear right now, and any off-label use should really be individualized depending on the patient situation and the scenario that they're in. Tranexamic acid may indeed have a role. The dosing scheme would be 1 gram in the first 10 and then 1 gram over the next hour, but if you're going to give it, it probably should be given early within the first 3 hours of injury. And that's it. Thanks very much.